Welcome back. Today we're talking about a topic that is heartbreaking and rarely talked about openly, but unfortunately quite common: miscarriage and recurrent miscarriage. It can be a really dark and isolating time for patients. Dr. Ruba, before we get into the science of why this is happening and what we can do about it, what's the first thing you say to a patient who's sitting in front of you after experiencing a loss or inevitably blaming themselves?
I think the most important thing to say is it's not your fault. I think patients do blame themselves and they really are seeking answers about why it happened to them. It's a very sad time, and sometimes immediately after a miscarriage is not the time to talk about investigation. It's time to understand their grief and the grief process and help them through that. So usually I give couples a little bit of information about what has happened, why it might have happened, the most common reasons for why miscarriage might happen, and then offer them at least some services that might be useful to them. So there are some great websites that you can go to that offer some support after miscarriage, particularly recurrent miscarriage. And I think then couples can reflect and absorb the information, and then when they're ready, they usually will come back and we'll start to do the investigations after we've had a discussion.
The terms miscarriage and recurrent miscarriage, medically speaking, what's the difference?
So recurrent miscarriage, generally speaking, is usually 3 miscarriages in a row, so one after the other. But age is also a factor. So if you are a woman of advanced age, so in their late 30s, then having 2 miscarriages in a row can also be considered to be recurrent miscarriage. So miscarriage itself is very common. It happens in about 1 in 5 pregnancies, and it often will happen in the first trimester of pregnancy, and that's generally speaking what we term miscarriage, so less than 12 weeks. Typically, miscarriage generally happens between 6 and 8 weeks of pregnancy, and it may result in the woman losing the pregnancy spontaneously. That means just unfortunately will start bleeding and pass everything themselves. And sometimes women only discover miscarriage when they have an ultrasound, and usually that's a dating ultrasound where we're trying to find out how many weeks pregnant the woman is, or we're following the pregnancy, and at 6 or 7 or 8 weeks or 9 weeks, we discover that the heartbeat has stopped, but she has not started bleeding and not miscarried.
So after this really difficult experience of miscarriage, how do you then move forward with your patient?
After the loss, couples always come back and see me, and we have a discussion about if we have been able to do any investigations. So sometimes we can send off some of the material from the miscarriage, some of the placental tissue or the fetal tissue, and have it analysed. And the most common reason miscarriage occurs is due to chromosomal abnormalities, so genetic issues. So if that's the case, then we try and find out if there are any genetic problems. So one of the investigations we do is actually looking at the chromosomal makeup of the couple. So checking the gender chromosomes and all the other chromosomes, in particular looking for a condition called balanced translocation. So translocation is the movement of material between chromosomes. There's no material that's been lost, but the material is in the wrong place. And so if one of the couple has a balanced translocation, they are more likely to have recurrent miscarriages because the information gets swapped or lost or duplicated when it gets together with the sperm or the egg, depending on who has the chromosomal issue. So that actually can be overcome through the process of IVF and then embryo testing. We can actually get that couple of pregnancy much more quickly. So it's an important but a small component of what causes recurrent miscarriage.
Okay, so if it's not a genetic issue, what other factors might play a part in recurrent miscarriage?
With recurrent miscarriage, it may be due to a structural issue with the uterus. So about 10% of women can have abnormalities in the structure of their uterus. And these abnormalities may include a septum, which is a little growth down the middle of the uterus, and it can divide the uterus or appear to divide the uterus. And if implantation of the embryo takes place on the septum, there isn't very good blood supply there, and that can cause miscarriage. Some uterine anomalies or structural abnormalities can be modified with surgery, but some cannot be. And there are also implications of structural abnormalities in pregnancy, including preterm birth, and abnormal fetal lie, so the baby can lie in a different position to the way we normally would expect it to lie. So there are some ongoing implications of structural issues in the uterus. There can be autoimmune conditions, we think. A big one is antiphospholipid syndrome. Usually women have a history of other issues, things like blood clots in the legs or blood clots in the lungs, or there may be a family history. And we do certain antibody testing. That's a blood test done on the woman to see if they carry those particular antibodies. And if they do, then we can certainly use low-dose aspirin or Clexane, which is an injectable blood thinner, and that can often help reduce the risk of miscarriage in those women. So we use it very early in pregnancy or even before the embryo is transferred. So often that's the approach we take. So basically blood tests and ultrasound to look at the structure of the uterus, and they can be done very simply through 3D ultrasound at an advanced ultrasound facility. So usually at a place that just does gynecological ultrasound, that can be very useful, or through MRI. If good ultrasound facilities aren't available, then structure can be looked at through MRI as well.
Interesting. That's super and very, very helpful. I suppose where I'd like to go next is sort of back to the IVF side of things. So if a patient comes to you with a history of recurrent miscarriage, what can we actually do differently for their next pregnancy?
It's a good question. I think that in terms of recurrent miscarriage, there is some information that we can obtain from the embryos before they're actually transferred back to the woman. It does involve freezing all the embryos on day 5 after they've been tested. So the purpose of that, of course, is to wait for the results to come back. And there is a delay in waiting for those results to come back. It can take, in some laboratories, 4 weeks and some 6. The testing of the embryo involves biopsying the outer part of the embryo, so what we call the trophectoderm, which is the what will become the placenta. So we don't take cells from the actual inner cell mass, which becomes the baby. So it again is done by a very experienced embryologist who actually uses laser to shave a few of the cells away from that area. And then these cells are sent to a laboratory where they're analysed and the DNA of the cells are actually revealed.
Yeah, okay, so that all sounds really positive. Are there any risks or downsides to this testing?
It doesn't stop us from having to discard embryos that we think are abnormal because of the testing. Unfortunately, the downside is that some embryos won't withstand testing, so the embryologist won't be able to test them. So there is a good chance that if perhaps you have 3 embryos, that one of them may not be testable at all. So that would mean having to put that embryo back blindly, so to speak, without knowing about its genetics. The advantage of testing is that sometimes, if we're very lucky, they can say, yes, this baby, potential baby, is very normal, or no, there are some very abnormal chromosomal makeup going on in this embryo, and by law, we are not permitted to transfer that embryo. The other confusing reports we receive are that of mosaic embryos, and that is where the confusion comes in. So mosaicism is basically, if you can picture a soccer ball with different white and black tiles on it, when we biopsy an embryo, we may get a black tile, a white tile, or both. And we do know that some embryos, the outer cell mass does contain abnormal cells that seem to have been kicked out from the fetus into the outer cell mass. And this outer cell mass can normalize over time. So the problem can be that we get a result that's mixed. And this mixed result means some of the cell lines are normal, some of them are abnormal, and there are different levels of mosaicism. So there can be high-level mosaicism. Generally speaking, we don't transfer those embryos either. There are low-level mosaic embryos. And again, usually a geneticist will have a discussion with the patient about what to expect from an embryo with that particular genetic makeup with a low-level mosaic embryo. And some of those can be safely transferred. And I've delivered babies of low-level mosaic embryos that have been completely beautiful, completely normal, completely fine. But we do recommend invasive testing of the pregnancy if we are able to get to 14 or 15 weeks, just to reassure us that the baby doesn't have a chromosomal issue going on. And remarkably, as I said, over time, these embryos are able to self-correct in some ways. So there is a big debate about whether or not we should be testing embryos at all, because we may be discarding some embryos that could have been healthy, normal babies. So I think these are things to keep in mind when you undergo testing, and that's certainly something I have a very long discussion with all patients, because most patients have heard about testing or have been offered testing at other clinics, particularly when they come in for a second opinion.
Okay, well, it sounds really complex, but for your patients who have suffered recurrent miscarriage, I guess these tests give you some control over their decision making and might reduce that risk of having to go through it again, right?
So recurrent miscarriage, perhaps heartache, can be saved by not transferring a very abnormal embryo. And as any woman who knows, going through a miscarriage is a long process as well. So you've taken all that time to get to 8, 9, 10 weeks of pregnancy, sadly lost your pregnancy, then gone through either medical management of miscarriage or surgical management, then recovered and then waited for your cycle to restart, which can again take a month, 2 months. So that's a very long journey to have to go through. So if we are able to shorten that period a little bit for women and perhaps avoid a miscarriage, a lot of women are actually very happy to have testing just to avoid going through the trauma of a miscarriage again. And that's completely understandable.
I suppose the other thing I want to try to understand is the anxiety of a subsequent pregnancy after a loss. How do you guide your patients on knowing when they're ready, both physically and mentally, to try again?
I think they guide me, to be honest. I just tell them, look, when you're ready, give me another call and we can start again. Some people need a holiday and some time away from the IVF process, which is completely understandable. Sometimes couples just want a little bit of reassurance, or they have no embryos left and they need to do another cycle. That can be a financial burden as well. So I think they need to be given the space and time to make their own mind up about when they will be ready. And I think physically, really when they've recovered after the miscarriage, it could be a month, it could be 2 months. It, again, is very dependent on the person. Some people are eager to jump back in and do things as soon as possible, but it is important to give yourself a bit of psychological space and to make sure that your partner's on the same page, because everyone can be affected differently by miscarriage, and not to forget your partner. They've gone through the experience with you, and often they take it just as hard, if not harder.
Yeah, thanks for mentioning us blokes in there, because it absolutely would. So what about when someone does fall pregnant again? How do you manage a patient and their partner's very natural anxieties about the possibility of miscarrying again?
I think that most patients will be eager to try again despite the disappointment they've been through. I think they just need reassurance and support through the early part of pregnancy. And that usually I do for my patients through ultrasound as early as we possibly can, to detect a fetal heart, to watch the fetal growth. So usually I actually offer my patients ultrasounds, weekly if they want to. It doesn't change the outcome, but it certainly changes their level of anxiety. And usually most of my patients say, that sort of anxiety starts to creep up again after 1 week. So that's how I tailored my ultrasounds. And certainly, the doors open in my rooms to come in anytime if they're worried. Of course, if they get any bleeding or spotting. And we support also through regular blood tests, checking the level of pregnancy hormone, beta-HCG, and the progesterone levels sometimes as well, depending on what sort of fertility treatment the couple's undergone. So yes, there's many things we can do early on to support patients who've had miscarriage. But I think the most useful is when they see the size of the baby grow, they see the heart rate is still good, and every week you get past 8 weeks is even more reassuring for the couple. And usually by the time they get to 10 weeks and there's a normal sized baby, good fetal heart, then it's time to think about doing things like NIPT or non-invasive prenatal testing. And most couples are feeling very good once they get the results of that back, and then they're regular ultrasounds.
I think that's really valuable information, and thanks for spending the time with us to go through it.
My pleasure.
Thank you for listening to this episode of Fertile Ground with Dr. Jyotika Ruba. If you'd like to make an appointment with Dr. Jyoti, please visit her website at drruba.com.au or call her Canberra rooms on 02 6106 9991. We'll be back with a new episode soon, so go ahead and hit that subscribe button to be alerted when it drops.